Hello, everyone. My name is Jamesia Hoyle, and I am the coordinator for the Next Generation Global Health Security Network. We are very pleased to have Professor Akin Abayomi with us today to lead a webinar on the face of a pandemic, the West African Ebola outbreak. Professor Akin is the Chief Pathologist and Head of the Division of Hematology, Faculty of Medical Sciences at the University of Stellenbosch in Cape Town, South Africa. He's a specialist in internal medicine and hematology, environmental health and biobanking. And Professor Abayomi studied at the Royal Medical College of St. Bartholomew Hospital in the University of London, where he obtained his first graduate degree in medicine. His primary focus has been on the concept of emerging diseases like HIV and TB and the development of laboratory and clinical capacity in Africa. He is currently the PI of the Consortium. Just as a reminder, as you have questions, I ask that you please type them in the chat box and we'll get to them immediately following the presentation. So at this point, Akin, I'll turn it over to you. Thank you.
Thank you very much, Jamesia. I wonder if you can hear me properly?
Yes, sounds good.
Okay. Welcome, everybody. And this afternoon, I'm going to be giving you an experience of the West African Ebola outbreak from the perspective of Africans that were on ground during the outbreak and the challenges that we faced during this devastating pandemic of the Ebola outbreak. So to start with, just to let you know, I'm based at the Stellenbosch University in Cape Town, South Africa, and I work at the Tygerberg Hospital, which is a multidisciplinary teaching hospital, where I'm a chief of pathology in the division of hematology, and some of my interests are in emerging infectious diseases and capacity development for the continent to cope with an increasing number of emerging infectious diseases that we're experiencing on the continent. So the face of the Ebola outbreak, what do you do when you have a rapidly spreading, highly infectious and deadly pathogen that has no known cure and is spreading in multiple densely, poorly resourced and populated cities of a region? How do you cope with such a scenario? Well, the bottom line really is that sub-Saharan Africa has some unique peculiarities. And I'm showing this slide because I want to highlight to you that using the number of pathologists per population gives you a surrogate marker of the medical capacity that exists on the continent. So on average, if you look at this slide, you will see that there are one pathologist for 15,000 people in the United Kingdom and one pathologist for 19,000 people in the United States. Now in Africa, some countries don't have a single pathologist, and many countries have a ratio of about one pathologist to anywhere from 5 million to about 1 million population. So that gives you an idea of the incredible deficiency that we have on the continent of Africa when it comes to medical manpower. So when you have emerging infectious diseases that are flourishing in an area that has a serious deficiency of human medical capacity, then that in itself is a recipe for disaster. Now, this slide shows you that Africa seems to have by far the largest burden of infectious and parasitic diseases in the world. And this slide shows you that in the deep red, that the number of deaths resulting from infectious diseases is by far heavier on the continent of Africa than anywhere else in the world. So the continent of Africa is where we would expect to see multiple recurring emerging infectious diseases that are capable of causing public health crises. So just looking back in time, then and now, over a period of about 40 years, in 1976 was the first recognized outbreak of Ebola in Zaire in Central Africa. And these are pictures from colleagues of mine who shows you the kind of infrastructure that we were using in those days, 40, 50 years ago, in many parts of Africa. Now, fast track to 2015, somewhere in West Africa, and I must express that nothing has really changed. We still have the same poor infrastructure and deficiencies in medical, human capacity and resource. So over a long period of time, it seems as if we really haven't made much progress in terms of creating an environment where we can cope with such outbreaks of pathological infections that can cause outbreaks. And this was clearly evident in the Ebola outbreak. So we are accustomed to makeshift facilities that are built when there's a crisis, rather than having permanent structures that can be there to service situations that as they occur from time to time. Now, on the 17th of July 2014, a frightening event occurred in West Africa, in Nigeria, that could have radically and dramatically changed life in West Africa, the continent, and beyond. It was a time and a week when the Lagos city, the metropolis of Lagos, came to a standstill. It was a time where there was a spread of an index case of Ebola from Liberia to Nigeria on an African Skies flight. This flight was carrying a Liberian diplomat who had been exposed to Ebola in Liberia because he was nursing one of his relatives. And he came on a flight to Lagos and he developed Ebola on the flight and on arrival in Lagos. This is a picture of the Commissioner of Health, Dr. Jide Idris, for Lagos State. And he was faced with the crisis of addressing an outbreak of Ebola in the Lagos city metropolis. Now, these slides showing you some very nice images of Lagos. But Lagos is what we call a megatropolis. It has 23 million inhabitants. Now, you can imagine how difficult it would be to control a highly contagious pathogen that is spreading through a city that is this densely populated. Just look at the crowds, and if you can imagine that Ebola was able to get into this part of Lagos in Nigeria, then we would have been sitting on a crisis of huge proportions. But luckily, Dr. Jide Idris was able to galvanize his team, and they used existing expertise to fast track an Ebola contact tracing mechanism where they were able to rapidly contain the outbreak through door-to-door contact tracing, and they were able to stem the outbreak in Lagos City and stop what could have been a catastrophic event. Nonetheless, patients in Lagos were dying and some patients were recovering. And Lagos is known to be a cosmopolitan city, and it is established that at least 12,000 people fly out of Nigeria on a daily basis to different corners of the world, as you can see from this slide. So if Ebola had taken Nigeria by storm, then there could have been an immense movement in a starburst manner across the rest of Africa and into the international communities. As you can see, the network of airlines across the world could have caused a global catastrophic event if Ebola had really taken hold of Lagos and the rest of Nigeria. Thankfully, that did not happen. But we recognize that Africa still has significant lack of preparedness for biosecurity threats. Ebola taught us that lesson. It exposed the complete inadequacy of our capacity to deal with pandemic events. We in Africa rely heavily on international support like Médecins Sans Frontières, Red Cross, Red Crescent, or Oxfam to handle most of our health crises on the continent. Africa has not fully adopted the international conventions that govern biosecurity, such as the Biological Weapons Convention, the United Nations Security Council Resolution 1540, and the Global Health Security Agenda. So we needed, as this outbreak was in its infancy in Lagos, and we also knew that it was roaring out of control in adjacent West African countries of Sierra Leone, Liberia, and Guinea, we had to take some immediate steps. The first task was to organize ourselves as African professionals and civil society and organize ourselves into a consortium to support the governments with preparedness and response. We felt it was urgent to organize the first African scientific conference on Ebola. There were conferences happening all over the world on Ebola, but none in Africa from an academic perspective. And the aim was to rapidly understand the magnitude of the problem, promote awareness, and develop an indigenous response mechanism, and definitely collaborate with our international partners. We also had to try and find immediate solutions if the outbreak continued to accelerate out of control. At that point in time, we did not know where the Lagos outbreak was going, even though we managed to bring it under control over a period of about 2 months. During those 2 months, we were not sure whether this outbreak was going to explode out of control as it had already done in our neighboring countries. So we established the Global Emerging Pathogens Treatment Consortium, otherwise known as GET. And GET was supposed to have the mandate of providing help, logistics, infrastructure, mobilization of support, expert support logistically, and the caring of samples and the caring of patients. And we brought many people together very quickly over a period of about 2 or 3 weeks. Many people on the continent of Africa and many international collaborators and philanthropic organizations rallied to our support. And we were able to get off the ground very quickly because the outbreak was raging out of control in several parts of West Africa. Now, GET collectively had several indigenous capacities. We had capacities in biobanking, biosecurity, biosafety, and bioethics, design of infrastructure and project management, data management, community engagement, blood product use, clinical trials, and genomics and bioinformatics. So we thought it was important that we organize the first conference, the first African conference on Ebola, which we were able to put together very quickly, and that was hosted by our counterparts in Dakar in Senegal in January 2014, at the peak of the outbreak in West Africa. At that meeting, there were several important dignitaries from around West Africa and the continent, and some international partners. And we met in Dakar, Senegal. And this was a very important meeting because it was the first time we were able to clearly identify what our deficiencies are, and we put those down in what we call the Dakar Declaration, which is a document that we use since then to strategize and plan out the future trajectory of how to respond and support governments on the continent of Africa. Now, historically, we know that Ebola has been coming and going for the past 40 to 50 years. There have been a number of outbreaks in different countries, mainly in Central and East Africa. And usually these are preceded by an outbreak in the ecosystem before it crosses over into the human population. But as you can see from this table, the number of cases was always limited to under 500 deaths, and it was always very quickly brought under control. Ebola was considered to be one of those sporadic infections that really affects countries in Central and East Africa that wasn't really of any global concern. So these outbreaks would be brought under control by infection control strategies, and that would be the end of that. However, the West African Ebola outbreak was different. It was different in many ways. It was the first time that we really saw an outbreak outside of the jurisdiction of East and Central Africa. It was the first time we'd seen an outbreak in West Africa. It looked different, and it was affecting countries that were not prepared for this kind of eventuality. And as a result of that, there was a heavy morbidity and mortality. There were at least 11,000 reported deaths before it was brought under control. And we have 14,000 survivors, which is the largest number of survivors that we've ever experienced after an Ebola or during an Ebola outbreak. Now, the outbreak had its epicenter somewhere in Guinea, in a place called Maliandu. And this picture shows some hollowed out trees just outside a little town where it is believed that some children were playing or trying to smoke out some bats that lived in these trees, in trying to catch the bats, which were roasted for protein consumption. This slide just shows you how this area used to be heavily forested. And over the decades, you can see that there's been dramatic deforestation and environmental degradation. And it is purported that these children were trying to hunt bats in this hollowed out tree. And one of these children came into contact with a bat. And unfortunately, this child developed Ebola, and no one knew what it was. And the child was treated by relatives and local traditional healers. And that was the epicenter and the spread of the outbreak. As you can see from this slide, you can see the epicenter starting there, and over a period of weeks and months, it started to spread across boundaries from Guinea into Sierra Leone, into Liberia, with increasing numbers of cases over the months from 2014 into 2015, reaching its peak around this time, and then starting to subside slowly, move on through 2015, and eventually towards the end of 2015, the outbreak was finally brought under control. So it spanned 3 years, from 2013 with its index case in Guinea to the end of 2015 when the last cases were reported in Liberia. So spanning 3 years. So why did Ebola spread so rapidly in 3 countries, Sierra Leone, Liberia, and Guinea? Well, we knew that these countries are quite wealthy in terms of mineral wealth, but there is profound poverty nonetheless. The countries have been ravaged by war and conflict and excessive extraction of resources. There's a lack of human resource in those countries. The epicenter of this outbreak was a remote location in a town bordering the 3 countries. So it was a border town, and therefore it was easy to spread into 3 countries simultaneously. This was never experienced anywhere else before. It was always confined within a geographical location within a country in East or Central Africa. But the nature of the epicenter of this outbreak was on a border city, and therefore it was able to spread very quickly into 3 countries that had these close border links. We had never heard of Ebola in West Africa before. We still don't know what the host is. And the clinical features appear to be very different from what we are accustomed to when it comes to the typical features of Ebola that we've seen in East and Central Africa. We're very inexperienced with handling category A pathogens like Ebola, and there was severe lack of specialized infrastructure in these 3 countries. This slide from my colleague shows, typically on the right, you would expect to see a patient with Ebola suffering with hemorrhagic features from the mucosal membrane. So usually from the mouth, the nose, or any other mucosal membrane, there would be bleeding. And therefore, it would be easy to diagnose Ebola when an outbreak starts. But in this case, like this picture on the left, there was very little bleeding, and there were more of the gastrointestinal features like diarrhea and vomiting. And these patients typically had copious amounts of diarrhea and vomiting in the West African outbreak, which was atypical. And therefore, for months, the health authorities did not realize that they were dealing with Ebola. It's only when the patient reached its terminal stages that you would start to see features of bleeding. And so it was able to spread. Many of the healthcare professionals thought it was something like cholera or malaria. It wasn't until this condition was spreading dramatically across borders into several communities that we started to consider that we were dealing with something else. And these arrows show how the movement of the spread across the three countries into other countries like Mali and to Nigeria. So over the weeks from 2013 into early 2014, the cases started to rise in the 3-4 countries, and it continued to exponentially increase. Now, what we would expect if there was infrastructure and capacity in place is that at the early reporting stages and the early response mechanisms would bring such an outbreak under control. But as this slide shows, you can see that these response mechanisms failed, and the outbreak was able to peak and run out of control and spread to many international countries, many regional countries, and across international borders. So Ebola is a category A pathogen. What do we mean by this? A category A pathogen is that any organism or biological agent that poses the highest risk of national security and public health threat, because it can be easily spread and transmitted from person to person, and it usually has no treatment. It results in very high levels of sickness and death, and it causes public panic and social disruption, leading to chaos and breakdown of law and order. And it requires very special action and infrastructure for public health establishments to bring it under control. So these are some of the scenes that we saw in the countries that were heavily affected. There was breakdown of law and order, there was social disruption, there was chaos and catastrophe, and there was very, very primitive infrastructure during the early weeks and months of the outbreak, with many people being treated in makeshift facilities, as you can see here. It wasn't until later on into the outbreak that these kind of organized establishments were set up by international partners that came in to render help to the countries affected, that we started to see these organized structures that were receiving on some occasion between 50 and 100 new cases a day. So the GET Consortium became active on ground, and this slide shows you some of the activities that we were and still are involved in. We were able to organize annual biosecurity conferences. We've worked on workshops with survivors, looking at their long-term welfare and research into survivors. We have biosecurity and biobank projects in Sierra Leone and Nigeria. We're advocating for the same in Liberia and Guinea. We've done some legislative gap review workshops to address the gaps in the laws of these countries that address the proper handling of public health emergency crises. We're working on convalescent plasma as a means of managing outbreaks caused by emerging infectious diseases. We're working on some editorial projects. We have an African story, the African perspective of the Ebola outbreak. We're planning to make 6 short TV series on the sequence of events of this outbreak. We have an Ebola art project for survivor welfare. We're collaborating with partners on promoting appropriate health infrastructure. And we've developed some fairly elaborate research projects to still answer the questions that we don't have readily available responses to in terms of what Ebola is all about and how it interfaces with other viral hemorrhagic fevers in the region. GET also has interns, fellows, and PhD students within the consortium. So some of the projects we're involved in, the convalescent plasma in infectious epidemics. Sometimes when you have an infectious epidemic that's raging out of control, that doesn't have any treatment, if you don't have a treatment and you're having people that are surviving from those infections, of course, many will be dying, but some will be surviving just by virtue of their genetic makeup. Then we are in a position where there is something in their blood, some antibodies in their blood that have helped them to survive the outbreak. So if we can harvest these antibodies from the survivors, then we can use this to treat new patients. And this is a picture showing some of the GET team on ground in Freetown, Sierra Leone, as we were working very closely with survivors, and all the people that are wearing black t-shirts are survivors, Ebola survivors. And we were working very closely with the Ebola survivors to convince them to donate what we call white blood, or the plasma. And inside this plasma is the antibodies that help them survive. And if we're able to use this plasma, obviously with conventional treatment modalities to make sure that it's safe, we're able to give this to patients who are developing, new cases who are developing Ebola. We wanted to answer the question as to whether the use of this convalescent plasma was a treatment modality that could be used in Ebola outbreaks. And these pictures just show some survivors that have been placed on these machines to harvest the plasma, and then this plasma would be processed and given to new cases of Ebola. We're still trying to develop this concept and perfect it in the sub-region of West Africa, so that in the future we can rapidly fast-track it if there is another Ebola outbreak or any other emerging infectious disease that has no definitive treatment. We are carrying out some biosecurity projects. Category A micro pathogens can be directed at humans, plants, animals, and can be a threat to crops and livestock. They can be used as bioweapons. So we are carrying out the assessment threats. We're looking at the possibility of non-state actors in the sub-region that may want to get their hands on samples of these deadly pathogens. And we're looking at what these threats could be in the sub-region. We're currently involved with a project in Sierra Leone where we're trying to reduce the security threat posed by the presence of thousands of Ebola samples that have been left over from the outbreak in less than secure facilities. We're trying to round up these samples and put them into internationally recognized facilities that have the requisite amount of security to protect them from falling into the hands of non-state actors. It is estimated that this outbreak produced over 300,000 Ebola-related samples in the West African region. And this is just a graph showing you the number of samples that are estimated to have been collected in Sierra Leone alone. And we are in the process of mapping out where these samples are, consolidating them into temporary locations, and with the help of some of our international partners from the Global Partnership Program, we're embarking on a very complex project where we are going to consolidate all these samples and their data into a permanent biosafety, biocontainment biobank in Freetown, where they can be kept safely and used into the future for academic inquiry and research. And these are some of the project team in Sierra Leone, a combination of medical personnel, military personnel, intelligence personnel, and logisticians that are consolidating the samples and moving them from location to safer biorepositories. We've developed a bespoke database where we're trying to consolidate the data that we can link up with the samples so that these can be very valuable, high pedigree samples that can be used and provided for collaborative research through international partnerships with the government of Sierra Leone. We're also involved in looking at the legislative structures of countries that were affected and seeing how their legislation can be strengthened to deal with pandemics of this nature into the future. Many of the legislative acts in many countries across West Africa and Africa as a whole have significant gaps in them that do not speak to how a pandemic can be managed under such circumstances. So it's important that we review the legislative mechanisms in several countries and recommend strengthening of these legislative tools to make sure that these countries are in a better position to manage outbreaks in future. So we learned quite a number of things, but there's still many things we don't know about Ebola. So, for example, we don't know what are the determinants of outcome in Ebola. We recognize that several people had several different responses to Ebola. Some would catch Ebola and become very unwell with multi-system disorder and ultimately fatal. Others would catch Ebola and they would become very sick but would survive. Some would catch Ebola and just have a mild illness, and sometimes not even requiring admission. And some people would catch Ebola and not even know that they had it. So there's a lot of uncertainty or lack of understanding of the pathodynamics of Ebola and how it relates to other viral hemorrhagic fevers in the sub-region. So there's a lot of unanswered questions, and therefore research into this outbreak is very important. It's very important that we safeguard the samples, we safeguard the institutional memory, we safeguard the data so that we can put research teams together to try and unravel some of these significant unknown questions about Ebola. For example, we still don't even know where the natural sanctuary or reservoir of Ebola is. Which animal is a natural reservoir of Ebola? That question is still to be answered. We've put together the African Biosecurity and Genomics Network after the Lagos conference, and we were able to define some research questions, and we've presented this proposal for funding through various international funding opportunities. We're also looking at infrastructure. What is the best and appropriate infrastructure for Africa, where we have extreme temperatures, we have lack of clean power, and yet we have abundant supply of sunlight and wind, and it is expensive to maintain infrastructure and to supply energy. So we are working with some of our international partners to try and figure out how to get appropriate technology that would be suitable for some of the infrastructure that we think we need to put in place in many of these countries that are prone to emerging infectious diseases that can cause public health crisis. We've been busy organizing the annual conference of emerging infectious diseases and biosecurity. The second conference was held in Lagos, Nigeria in July 27th to the 29th. It was a very successful meeting. We are now preparing for the third African Conference on Emerging Infectious Diseases and Biosecurity. We're going to be hosted in Accra, Ghana from the 16th to the 18th of August 2017. And our hosts are going to be the Noguchi Memorial Institute for Medical Research at the University of Ghana in Legon, Accra, and their counterparts in Kumasi, the KCCR Institute. And together, the KCCR and the Noguchi will host us in Ghana for the third meeting. And I'm using this opportunity to invite you to that meeting. The theme for that meeting is pandemic preparedness, biosecurity and infrastructure in the wake of the Ebola outbreak. We have 6 parallel themes that we'll be addressing during the 3rd conference in Accra: emerging infectious diseases as an accelerated phenomenon and the aftermath of the Ebola outbreak, biosecurity and biothreat reduction, biobanking, public learning and understanding of science and science communication, the need for a vaccine and immunological strategy for the Ebola belt of Africa. And we also have the 6th sub-faculty, which is our junior faculty, where we're trying to mentor the next generation of African scientists to combat emerging infectious diseases on the continent of Africa. These are some of the faculty members for the 3rd meeting who are responsible for organizing the academic content of the next meeting in Ghana. And this team have already started working to put together the academic program for the Ghana meeting. And you're all very welcome. The information on this meeting will be on the GET website, and we will be able to answer any questions that you may have about the up-and-coming conference in Ghana. So I'm going to pause here now and take questions. On this slide, I just want to thank many of the donors that have been responsible for many of the activities that the GET Consortium has been able to conduct in the various countries, from the Médecins Sans Frontières, University of Stellenbosch, the National Health Laboratory Services of South Africa, the South African National Bioinformatics Institute, our counterparts in the West African Task Force for Emerging and Re-emerging Infectious Diseases, and the Global Partnership Program from Canada that have been incredibly supportive of many of our projects across the West African region. Thank you very much for your attention, and I'll be happy to take some questions at this point.
Akin, this is definitely thank you for an amazing presentation. So there are quite a few questions that have come into the chat box, but I do want to remind people that if you do have questions, please enter them in the chat box and I will relay them to Akin for his input. So we'll start with the first few questions that we have received already. So the first question is, why, from your perspective, was the WHO so reluctant to announce the Ebola outbreak as a public health emergency of international concern?
Thank you very much. Well, I think part of the problem was that the outbreak, the index case was in December 2013. And as I explained in the presentation, that it was an atypical clinical features, and it went on for about 3 to 4 months before it was finally diagnosed as Ebola. So there was a lag period of about 3 to 4 months, in which case it was able to spread very quickly because we didn't know what we were dealing with. At that point, the WHO obviously and several international health agencies came, but because it was spreading in very remote parts of 3 countries, it wasn't immediately clear the magnitude of the outbreak, because these are very remote, these are huge distances in 3 very large countries of Sierra Leone, Liberia, and Guinea. And it's not easy to get accurate surveillance data, especially when there is a very chaotic environment on the ground. So I believe that these were some of the factors that delayed the WHO in arriving at a tangible understanding of the magnitude of this outbreak. But eventually, they responded very quickly and declared this a public health emergency of international concern.
Awesome, thank you. The next question is, what kind of impact do you feel that the African CDC will have in the landscape of disease management in the region, and how do GET's current projects or future projects intersect or complement these other initiatives?
Yeah, so the CDC, the new CDC initiative in Africa is a long-awaited event. We're very, very excited about it, and I think Ebola was able to fast-track this initiative. So we're very pleased that this is happening. We, as GET, are functioning very much on ground, operationalizing activities. We're at the cutting edge of what's happening on the ground in terms of the biosecurity concerns. But we ultimately will rely on the CDC to forge the strategies and the policies that need to be implemented across the countries, across Africa. And we're looking forward to the leadership of CDC. And we are very, very keen to synergize with the evolving strategies that CDC Africa is going to evolve very quickly in the next couple of months as they crystallize their plans to take off in Addis Ababa. So GET is very excited. We are very keen to share some of our experiences with CDC and to be a resource to the CDC Africa.
Wonderful. So the next question says that Ebola was tragic and shocking, but other health threats exist and persist in these communities. So how do general preparedness and health system strengthening activities best leverage Ebola's lessons?
So that's a very, very important question. And yes, it is true. And it is critical that we appreciate that Ebola came and went. It will come again, we're quite certain. But there are other viral hemorrhagic fevers and other highly infectious pathogens that are causing outbreaks all the time. As we speak, there are breakouts of Lassa fever in many countries across West Africa. It's pandemic, it's ongoing, it's there all the time. It kills thousands of people every year. So sometimes there's a silver lining across a dark cloud. And we believe that Ebola has been able to expose the significant lack of infrastructure and capacity that we have in these outbreak-prone environments in sub-Saharan Africa. So the lessons we've learned from Ebola are very deep and painful, but they're very meaningful. And we believe that from the lessons we've learned from Ebola, we're able to fast-track the capacity of many African countries to increase their awareness, their preparedness, and their speed of response to other such like emerging infectious diseases that are able to spread very quickly and cause chaos and catastrophe and lots of suffering, pain, and death in the communities across sub-Saharan Africa. So as painful as Ebola was for us, it has certainly opened our eyes. It has certainly drawn the attention of both our health communities and our policymakers on the continent and internationally to the need to focus attention on capacity, preparedness, training, and resources in these areas that are subject on a yearly basis to emerging and re-emerging infectious diseases, which are biosecurity threats, and they affect our economic platforms drastically.
Thank you. So we have another question, and I think that you have answered a bit of it, but there's a second half that I'm actually interested in knowing the answer to as well. So it says the breakdown of a weak health system were at the heart of the outbreak. How would GET typically complement some health system strengthening efforts currently underway in these three primarily affected countries in order to contain such outcomes in the future? And how can the next generation global health security network efforts?
Right. So after the Ebola outbreak, there was a complete breakdown of, uh, of, um, of structures. There was devastation. Lots of healthcare providers were infected by Ebola. So in an environment that already has a deficit of healthcare personnel, many of the healthcare professionals were at the front line of the response. And because of our inadequate preparedness and capacity and training, many of our colleagues contracted Ebola and many died. So we have an even more serious deficit of human personnel on ground. Unfortunately, we have to start from the bottom. We have to train, we have to develop capacity, we have to introduce infrastructure, we have to expose people to international standards of biosafety and biosecurity, biobanking, and emergency preparedness. All these things have to take place. Then we can't do them overnight. This is a long-term project. And what we're doing on ground now in countries like Sierra Leone and Nigeria is to help them restructure, to help them develop infrastructure with the aid of our international partners. We have a lot of African expertise on ground. As I pointed out in my presentation, we're trying to harmonize a African approach so that we have a one standardized approach across the countries, which makes it easier for us to collaborate. We're very, very interested in international partnerships. We openly welcome the support of the Next Generation Global Health Security Consortium and the likes of other interesting consortiums that are interested in this space of biosafety and biosecurity. We can't do it alone. We depend on your support to help us achieve what needs to be achieved on the ground in many of the countries across Africa. And particularly, we're looking at regulatory mechanisms, ethics, and social justice. Because, you know, what normally could happen in an environment like this is Africa could be taken advantage of by certain organizations if we don't have the correct regulatory mechanisms on ground. So we're paying particular attention to the governance and the regulatory mechanism of the control mechanisms that we need to put in place to be able to effectively and indigenously respond to such crises.
Great, thank you. Your presentation mentioned quite a few activities that GET is currently undertaking. The question is there a briefing or a booklet of sort available that really lists out what GET has done so far and what you plan to do in the future?
Yes, we have that information on our website, which is getafrica.org. And we also have on request a kind of catalog of what we've been doing, what we're currently engaged in, and what we hope to do in the future. So if you visit our website, which is getafrica.org, you will find a lot of resource on that website. And if you just send us an inquiry or write to me, I will be happy to respond to any questions. I was unable to fully expand on all the projects that we're involved in because of the time constraints, but there are a lot of things that we're doing, and we'll be happy to explain what we're doing and particularly collaborate with interested parties.
Thank you. The next question is, how can we engage diaspora healthcare professionals and ensure a proactive strategy is in place before an outbreak?
Yes, this is the key. Well, engagement, the platform that we have created that we feel will accelerate engagement is through our annual conferences, where we would love to have you attend our conferences. This is the third of such conferences. If you come to the conferences, and the information is out on our website as well. If you come to the conferences, you will be in a position to meet with us and to meet with other people that are involved in developing capacity and involved with research and some of the projects that we're involved in. And that becomes a forum for us to discuss in more detail how we can enter into collaborative joint ventures. The important thing is to be in a better position to respond in the future so that we don't have these lag times where an outbreak caused by a highly infectious pathogen is able to get out of control. Now, Ebola is an infectious pathogen, but it is not as infectious as a flu or an airborne pathogen. You have to actually touch someone with Ebola, as we know it, as we understand it now. You have to come into close contact with someone, physical contact, to contract Ebola. Now, what if we are faced with an epidemic that's caused by a highly contagious pathogen that is airborne, that can spread just by being in the same environment as someone without necessarily having a physical contact with them? Ebola would look like child's play compared to such an outbreak. Now, we didn't do very well with Ebola. It took us almost a span of 3 years to bring Ebola under control. We didn't handle it very well. The international community didn't know how to handle it. We didn't know how to handle it on ground. And so Ebola, I see Ebola as a test case scenario, and we didn't do very well. So it's not an African problem, it's a global problem. We need to look at how we managed Ebola, learn from the mistakes we made during the Ebola outbreak, and be prepared for something even more devastating than Ebola. And we are all expecting some form of pandemic flu in the next decade or so. And if we just ignore what the lessons that we should have learned from the Ebola outbreak, then we'll only have ourselves to blame when we're faced with something that's even more contagious and able to spread very quickly and kill millions of people in a very short period of time.
Great, thank you. So I'll give people just a few more moments to ask any questions that they may have via the chat box. I actually do have one question for you, Akin. In your presentation, you mentioned the importance of reviewing the legislature to recommend various opportunities for strengthening the healthcare system or just capacity to meet this awareness. And I just want to know a little bit about your perspectives on the role of advocacy and even how we as NextGen may be able to implement some grassroots advocacy throughout the region.
Yeah, so there are several layers of advocacy. We need to advocate at almost the highest level, which in Africa would be the Africa Union, and then the sub-regional health excuse me, the sub-regional health authorities. Then we need to move to the ministries of health, and then the provincial health authorities. And then we need to do a lot of work in our academic institutions, the institutes of higher learning, the secondary education, and even at the primary level. And of course, then we need to move into the grassroots environments, the rural primary healthcare centers. So there are multiple layers of advocacy, and there are tactics and techniques and strategies that we need to deploy for each and every of these levels of necessary communication. That's why in the conference, we play a lot of emphasis on what we call the public learning and understanding of science and science communication. We feel that science communication and learning of science is a crucial and critical aspect of the response preparedness. And we will continue to emphasize community engagement and public learning and understanding. After all, it may come as a surprise to you, but the Ebola outbreak was brought under control simply and effectively by public learning and sharing of academic information and science with communities and rural practices and cultural practices, that if we hadn't been able to convince our rural communities to change certain cultural practices, we would not have been able to bring Ebola under control. So every level of advocacy is important. At the highest level, we need to ensure that our governments are diverting enough resources to build strength, resilience, infrastructure, and training. At the highest level, Africa is not spending enough money on health, is not spending enough money on research and development. We're highly dependent on international and philanthropic funding from abroad to conduct research in Africa. That should not be the case. African governments and African philanthropists should be primarily responsible for research and development on the continent. Not to say that we don't welcome international funding. We do. We certainly appreciate it. And if not for that, we wouldn't have any research and development, or very little research and development. But the governments of Africa and the continental policymakers must recognize their responsibility to drive indigenous research and to put adequate amount of resources into research and development, which will help to build robust, resilient health infrastructure and awareness.
Thank you. So we have another question. It says there are many on-the-ground implementers doing similar things. How do you know who's doing what, and is there?
Sorry, I didn't get the question, but I think you were saying there are multiple players on the field trying to do the same thing. How do we coordinate our efforts?
Absolutely. And if there's any overlap, how are you coordinating those efforts?
Right. We're trying very hard because resources are scarce. So we're trying not to duplicate things. So for example, in West Africa, we have the water, or the West African Task Force for Emerging and Re-emerging Infectious Disease Outbreaks. So we're working very closely with water to make sure that we're not duplicating efforts. We are in close contact with WHO and several other, and WAHO, the West African Health Authority. We just want to make sure that we channel the resources in a way that's efficient and focused. So we certainly don't want to duplicate things. We want to meet other organizations that are involved. We want to collaborate. We want to join forces, and we want to have a strategic approach that conserves the resources and conserves the human capacity in West Africa and across the continent to ensure that we're working hand in hand and synergistically to address the numerous deficiencies that we have on the continent. The deficiencies are huge. Even if we work tirelessly for the next 10 or 20 years, we're just going to be scratching the bottom of the barrel. But with the advent of the new Africa CDC, we believe that their leadership is going to drive a lot of the agenda, and we're very happy to align our efforts and our resources with the objectives and the strategic vision of the Africa CDC and the regional CDC institutions as they develop over the next decade or two. It's important that people come to the conferences so that we can find out what everybody is doing, and we can exchange notes and compare agendas and compare our strategic visions and align our efforts to make sure that we're all working in the same direction and dovetailing and operating together.
Awesome. And with that, we are at time. I want to thank you, Akin, personally for hosting the webinar with us today. It's very informative and a lot of great information to move forward, especially connecting with the GET Consortium. I want to thank everyone who joined our webinar today. I encourage you to continue to connect with Akin beyond even our webinar today. Reach out to him via email. Also view the website to see some of the great things that they are doing throughout the region, and also to continue to connect with the Next Generation Global Health Security Network. Subscribe to our channel. We try to host these webinars at least once a month, and connect with us via our website as to see any upcoming events that we may have. So thank you all for joining us today.
Thank you very much. Bye-bye.